Hello and welcome to Headline News in Neuroendocrine Tumors, or ENETS. I'm Steve Highsmith. This series of videos will focus on several important abstracts presented at the 8th Annual European Neuroendocrine Society meeting held March 9th to 11th in Lisbon, Portugal. Throughout 2011, Oncology.TV will bring you in-depth coverage of the latest data and abstracts presented at major Neuroendocrine Tumor Society meetings. In this segment, we have Dr. Jack Ishak with us to discuss the overall survival analysis of sunitnib after adjustment for crossover in patients with pancreatic NET, and specifically the impact of crossover on clinical trials. Doctor, can you talk about the objective of your trial?
The trial examined sunitinib in pancreatic neuroendocrine tumors, and we examined the outcomes from the study in the context of the crossover issues that were observed from the placebo arm into the sunitinib group, and examined ways of adjusting for the impact of that crossover on outcomes like overall survival.
What are the implications of that crossover and the methodology used for the trial?
Well, crossover is a fairly common occurrence in oncology trials, both for ethical reasons and practical reasons. They occur more and more in phase 3 studies and various types of oncology studies. The implication ultimately is that as patients progress with the reference treatment, or usually placebo or standard of care, they're offered the opportunity to receive the new experimental drug. The ultimate impact of that is the outcomes that are observed reflect the both impacts of the original randomized treatment, placebo or standard of care, as well as any benefits patients may have received from the new experimental drug. And typically, if the experimental drug has some benefit on outcomes like overall survival, what this will do is it'll attenuate any difference that can be observed in overall survival benefit between the experimental and reference group.
Well, please elaborate further. What were the results of the crossover?
In the sunitinib trial, a large proportion of patients crossed over. Among the 85 patients receiving placebo, and among those who progressed, around 80% crossed over at progression. So you can understand that that's a substantial portion of the population who's getting the experimental drug. Not only was crossover common, it also occurred early. By 3 months into the study, about 30% of the crossovers had occurred. By 6 months, almost half of the placebo group had been receiving sunitinib. Therefore, the influence of the crossover is prominent right from the early portions of the trial. Therefore, when you examine the overall survival patterns in the two groups, even though there is a clear separation and there is a survival benefit apparent for sunitinib even early on in the trial, there's reason to suspect that that difference is attenuated and it's potentially larger than it would have been had no crossover occurred in the trial.
Is there an effect then based on when the crossover occurs?
Yes, certainly. The earlier crossover occurs, the longer patients are exposed to the experimental drug, the longer potential there is for them to benefit from it, and the greater attenuation that could be observed. I should also note that in addition to the timing and the number of patients crossing over, there's typically a selection process that also happens. Not all patients who progress will cross over. Usually the physicians and the patients will decide together whether receiving the new drug is going to be beneficial for them, and you can imagine that those who are expected to benefit most will be the ones crossing over. So not only are patients getting a new, potentially stronger medication, but it's also patients who a priori are expected to benefit who are going on to get this outcome. So that means that there's a dual effect going on, influencing the outcomes in the group randomized to placebo, where patients are selectively being given medications that are expected to work well for them.
Looking at the conclusions of the phase 3 pancreatic NET trial, what are some of the key takeaways then, as well as your thoughts on the implications for patients going forward?
Well, Steve, this was a very interesting set of analyses that we undertook to try to adjust for the impact of crossover. There isn't a very clear or definite standard in terms of how to deal with crossover. There are many approaches analysts tend to use, such as censoring patients when they cross over or dropping them from the analysis altogether. And all of these are biased in one way or another, and they don't fully control for the impact of crossover. So we were able to apply some more novel statistical methodologies, in particular a type of model called a rank-preserving structural failure time model that effectively corrects for the impact of crossover. And what we found in our analysis in the sunitnib trial was that this led to a substantially higher estimate of the potential benefit of the drug. The crude ITT analysis suggested already a substantial reduction in the risk of death. The hazard ratio was about 0.41, which suggests a 60% reduction in risk almost. When we applied the rank-preserving structural failure time model, we obtained a hazard ratio of around 0.18, so suggesting a reduction of closer to 80%. Now, we are aware and recognize that this is a relatively small trial and relatively few deaths were observed, so one must be very careful in interpreting the strength of the result in light of this relatively small sample size, so it's precautionary to look at it perhaps more as suggesting an upper limit of the potential benefit, but nonetheless, it reveals that crossover can have a substantial effect in the outcomes you observe.
So, Dr. Ishak, based on your concluding remarks, how do you think these crossover effects will impact endpoint analyses, and what should our audience think about when looking at these approaches?
Well, as I noted, crossover is difficult to avoid and will be part of new studies as they are done. What's important to understand is which outcomes are most affected by crossover. Since crossover usually occurs at progression, outcomes like time to progression and even progression-free survival are most of the time not affected by crossover because the crossover happens as a result of that event. Overall survival is the outcome that is most affected by crossover, and therefore trialists and analysts should be wary when they look at overall survival outcomes during interim analyses or final analyses and realize that if there's a substantial number of patients crossing over, results based on the overall survival analysis are likely biased. And therefore, methods such as the rank-preserving structural failure time model, as well as others such as the inverse probability of censoring weighted models, should be considered to adjust for the impact of crossover and get a more realistic and an unbiased understanding of what the benefit of the new treatment might be.
Doctor, thank you for sharing your insights with us. That's Dr. Jack Ishak discussing the objectives of his trial. We thank all of the experts who participated in this edition of Headline News in NETS. I'm Steve Highsmith. Be sure to watch coverage on the latest news in NETS right here on Oncology.TV.